Good evening to everybody. It is indeed a nostalgic moment for me today, as I have been given the honor of delivering the first lecture of the 17th APGAP, the APGAP 2020, which is the 17th in the series since we started way back in 1984. I have indeed been fortunate as I have been directly involved with 15 of these APGAPs and indirectly involved in two of them. And therefore, I find myself very privileged to have been part of all the APGAPs until now. I must congratulate Dr. Manjunath and the Manipal Anaesthesia family, the think tank of the Manipal Anaesthesia family, for having decided to concentrate this year on basic sciences and particularly physiology, because I am of the opinion that physiology, a good grounding or a good understanding of physiology is very important for us to practice anesthesia and intensive care on a firm footing. And though I may be a bit biased, among all the systemic physiologies, so to say, I believe that for an anesthesiologist, the cardiovascular physiology and respiratory physiology are very, very important. And I'm glad that the department decided to concentrate on basic sciences. And once again, I thank the Manipal Anaesthesia family, led by Dr. Manjunath, for having given me this opportunity to speak on applied respiratory physiology. Now, I'm going to divide my talk into three parts. Part one will be before the break of 10 minutes, which will be after approximately 40 minutes. And following the break, I will follow with part two and part three of my talk. And when I started looking at what I should cover or what I need not cover as far as respiratory physiology is concerned, it was a very difficult task for me, because covering respiratory physiology in a matter of 80 or 90 minutes is not an easy task. It is a Herculean task. And therefore, I chose some of the topics which obviously has a personal bias in it. And I thought I would cover 9 aspects of respiratory physiology in the first half of my talk today. And 4 of the topics that I would be covering are listed on this slide: tidal volume, functional residual capacity, closing capacity, and atelectasis. And the latter part of the first part will talk a bit about compliance, airway resistance. Of course, no talk on respiratory physiology is complete without compliance and airway resistance being mentioned. We'll also look at ventilation-perfusion and its distribution and how it impacts the flow rate and peak inspiratory flow rate. Starting with the first of these topics, which is tidal volume. When you open up any chapter on respiratory physiology, the very first thing that the authors of the chapter would address is the various volumes and capacities. And we know that there are at least 4 volumes and 4 capacities that are important for us to know as anesthesiologists. And the first among them is what is called the tidal volume, which is defined as the volume of air that is moved into or out of the lungs during a normal, quiet breathing. And of course, different books give different values for the normal value of tidal volume. The pure physiology books talk about 5 to 7 ml per kg body weight, whereas the textbooks on intensive care and respiratory care talk about 5 to 8 ml per kg. But I think to simplify the matter and for us to remember it easily, I've chosen to put the normal value down as 5 to 7 ml per kg. And in this, if all of us remember that tidal volume is normally 7 ml per kg body weight, that should be sufficient for us to tackle respiratory physiology. But just as we defined tidal volume, we also need to know the definition of vital capacity, which is nothing but the maximum amount of air that we can breathe out following a maximal inspiration. And this is one of the lung volumes and capacities that we need to remember. And why do we need to know about tidal volume and vital capacity? Obviously, we need to know about the tidal volume because, be it in the anesthetic location or be it in the ICU, we put patients on a ventilator and we need to calculate what should be the tidal volume we will be delivering to these patients. And taking a value of 7 milliliters per kilogram body weight, if you have a 50 kg patient, it will be 50 times 7 or 350 ml, or a 70 kg patient, it will be 70 times 7, 490 or 500 ml. So I can say that for an average of 50 to 70 kilogram patient, you would be setting a tidal volume of 350 to 500 ml on your anesthetic ventilator or on your ICU ventilator. Now, it also becomes important for us to know tidal volume, the normal tidal volume, and the normal vital capacity, because we make measurements in the ICU in order to decide when to put a patient on ventilatory support, when to initiate ventilatory support. And as a corollary, we also look at the same numbers as to when we can wean off ventilatory support. And for this, we can remember that ventilatory support is indicated when the tidal volume is less than 5 milliliters per kilogram. And if the maximum amount of gases that the patient can move or can breathe out following a maximal inspiration, remember we're talking about a patient who is in respiratory failure, if this falls below 15 ml per kilo, the vital capacity comes to less than 15 ml per kilo, it once again becomes an indication for initiation of ventilatory support. And as a corollary, we can wean off ventilatory support when the tidal volume is more than 5 ml per kilo or the vital capacity is more than 15 ml per kilogram. Now, keeping this in mind, several decades ago, when I was doing my residency about 40 years ago, we believed that the larger the tidal volume we deliver, the better it is for the patient. And of course, in those days, we also had simpler machines. We didn't have machines that were capable of measuring inspired and expired tidal volume. We had breathing circuits that were, quite compliant by themselves. So we had to deliver larger tidal volumes from the machine in order to take care not only of the patient's lung compliance, but also the compliance of the breathing tube. And therefore, we erred on the side of safety by setting tidal volumes in the range of 4 to 10 ml per kilo. In fact, patients with neuromuscular disorders or post-operative patients even received higher tidal volumes of 10 to 12 ml per kilo. And patients with COPD or asthma, despite their having an airway obstruction, despite their having bronchospasm, received tidal volumes up to 8 to 10 ml per kilo, albeit at slower respiratory frequencies. Now, as we went along and merrily delivered larger tidal volumes to our patients, over the years we realized that there is something called volutrauma, which is essentially trauma occurring to a lung that has been diseased, a pathological lung that is frequently expanded, in fact, overexpanded and allowed to come back to its normal volume, breath after breath. And this led to something called volutrauma. And with our realization of this concept of volutrauma with large tidal volume breaths being delivered, intensively started using lower and lower tidal volumes for intermittent positive pressure ventilation. And finally, when we learned about acute lung injury, or ARDS as it is called, which actually amounts of which caters to about 8 to 9 patients out of 10 who are admitted into an ICU with respiratory failure. These patients have a low compliance because they have a problem with their surfactant. And by ventilating patients with acute lung injury and ARDS, we realized that actually we have to even drop the tidal volumes even further. And we went down to as much as 4 to 8 ml per kilo in acute lung injury. We started off with 8 ml per kilo. And as we measured the blood gases, as we looked at the patient's respiratory mechanics as we went along, we slowly brought this down from 8 ml per kilo to about 4 ml per kilo, all the while maintaining the P plateau to less than 30 centimeters of water, because we know that when the lung is not very compliant, the plateau pressure tends to become very high. So in order to avoid barotrauma to the lungs, we had to keep an eye on the plateau pressure, which we needed to keep less than 30 centimeters of water. And with a reduction in alveolar ventilation and the inevitable buildup of carbon dioxide in the body, we needed to increase the frequency of ventilation to 20 to 30 breaths per minute in order to increase overall alveolar minute ventilation and drive out the carbon dioxide. And this was elegantly described by Gattinoni and his workers and co-workers as what we now call lung protective strategy, a term coined by Gattinoni and co-workers, or also known as the baby lung concept. We go on to the next point on respiratory physiology that I would like to talk about, and that is functional residual capacity. Functional residual capacity is a volume of air remaining in the lungs at the end of a normal expiration. So, which means that at the end of a normal expiration, if we take an extra effort and try to breathe out some more air, we'll be able to breathe out to a particular lung volume, which is called the residual volume, below which we cannot breathe out any more air. So, from the FRC, from the functional residual capacity level, as we breathe down to the to the residual volume level, we breathe out what is called the expiratory reserve volume. So at functional residual capacity, the amount of air that remains in the lungs is residual volume plus expiratory reserve volume. Now, what is unique about functional residual capacity is that normally when the lungs are taken, let's say you experimentally take out the lungs out of the chest wall, the lungs have a tendency to collapse towards the hilum, whereas the chest wall has a tendency to spring outwards away from the hilum. And at functional residual capacity, there actually exists a balance of forces between the inward elastic recoil of the lungs and the outward chest recoil of the chest wall. And at functional residual capacity, these two forces, the inward pull of the lung and the outward pull of the chest wall, tend to get balanced out. And that is the importance of functional residual capacity. If we need to put a number on what is the volume or what is the functional residual capacity like in a normal 70 kg individual, it's around 35 ml per kilogram body weight. So just to revise the numbers, a tidal volume of 7 ml per kilo, a vital capacity of 70 ml per kilo, and half of 70, a functional residual capacity of 35 ml per kilo. Now, what is the importance of functional residual capacity? FRC provides a reserve of oxygen in the lungs, and if you imagine that we are breathing at a rate of 18 breaths per minute and our heart beats about 72 times per minute, you find that for every breath that we take, the heart beats about 4 times. And the right heart pumps deoxygenated blood from the right ventricle into the pulmonary circulation for oxygenation, and therefore there needs to be a reservoir of oxygen within the lungs from where the blood that is being circulated through the pulmonary circulation by 4 consecutive heartbeats is able to pick up oxygen. And that is what the functional residual capacity provides. So FRC is actually the buffer or the reserve of oxygen within the lung, from which 3 to 4 consecutive heartbeats are capable of picking up oxygen. And then we take another breath and replenish the alveolar oxygen with more oxygen from the atmosphere and remove the carbon dioxide that has been accumulated in the alveoli. Now, FRC is actually maximum when we are sitting upright. And that makes sense because in the upright position, the diaphragm is free to move. And if the diaphragm is free to move away or without the hindrance of the abdominal contents pushing it up, you can imagine that breathing will be much easier. And therefore, FRC is highest in the sitting position. And once we assume a supine position, we lie down supine, the FRC is reduced by a value of about 0.8 to 1 liter. And this happens because the weight of the abdominal contents push the diaphragm up and restricts the downward movement of the diaphragm and thereby restricts the expansion of the lung itself. And it results in a compromise of the FRC, the functional residual capacity, to an extent of 0.8 to 1 liter. Induction of anesthesia in the supine position further reduces the FRC by a factor of 0.4 to 0.5 liters. And this is what is shown diagrammatically here in this particular diagram. On the x-axis, you have the age from birth right up to 80 years of age. And on the y-axis, you have the lung volumes in liters. The red line, the sloping red line, starts off at about 10 years of age and indicates the FRC as the person grows older from 10 years to 80 years. And you find that the FRC increases with age. The reason for an increase in FRC with age is because the aging lung loses its elastic recoil property. And because of this loss in elastic recoil property of the lung, the FRC increases with age. And the red line, mind you, actually depicts the FRC in the sitting position. When you look at the green line that is running parallel to the red line, it is indicating the reduced FRC of, as I said earlier, about zero point 0.8 to 1 liter reduction in FRC with the assumption of the supine position from the sitting position. And this again slopes upwards as we age, indicating that though FRC is reduced from the sitting to the supine position, this also has an age-related change as we look at the graph from 10 years up to 80 years. Now, induction of anesthesia in the supine position further reduces the FRC, and that is what is indicated by the parallel blue line here. And therefore, these three lines actually summarize what happens to FRC in the sitting position, in the supine position without anesthesia, and in the supine position with anesthesia. We'll remember this diagram because a little later we'll also be talking a bit more about this. Now, I mentioned that the FRC, the functional residual capacity, actually maintains the reservoir of oxygen in the lungs, and therefore, as anesthesiologists, we tend to build up this reservoir of oxygen by a technique known as preoxygenation. When you and I are breathing room air, we breathe in roughly about 20% oxygen and 80% nitrogen. Of course, oxygen is required to sustain life, but what is the purpose served by nitrogen? Nitrogen, we know, is a gas that is not very soluble in blood, and by being an insoluble gas, it remains to a large extent within the alveoli and acts as a pneumatic splint to keep the alveoli open and to prevent the alveoli from getting shut down or atelectatic. Very much like the pole of a tent, what we call the tent pole that holds the tent open once the tent is pitched up. So essentially, nitrogen, by being non-absorbable, serves as a pneumatic splint and prevents absorption atelectasis. Now, during pre-oxygenation, with all good intentions, we give 100% oxygen to the patient for a few minutes. Generally, 3 to 5 minutes is the time that we pre-oxygenate our patients for. And this is done with the idea of creating a margin of safety should we encounter an unanticipated difficult airway. Right. Now, when we do this, though we do this in the interest of safety, could this have a harmful effect? When we fill the lungs with 100% oxygen, oxygen is definitely more soluble in blood, and therefore, by absorption of all the oxygen, it can lead to what is called absorption atelectasis. And this can be avoided by pre-oxygenating with a tight-fitting mask, a tight-fitting breathing system, and using a CPAP of around 5 to 10 centimeters of water. Pre-oxygenation in a slightly head-up position by favoring diaphragmatic movement, by favoring free diaphragmatic movement, also provides an added advantage to this pre-oxygenation technique. So pre-oxygenation in a slightly head-up position of, let's say, about 20 degrees head-up with a tight-fitting mask and a CPAP of 5 to 10 centimeters of water is probably the best way of providing pre-oxygenation. Now let's come to the end of an anesthetic, where very often most anesthetists administer 100% oxygen to fill up the lungs with oxygen and also to remove the anesthetic gases from the air, from the alveoli. And we also sometimes provide suctioning of the endotracheal tube, particularly if there's a reason there are secretions in the endotracheal tube. And definitely we provide suctioning of the oropharynx to clear all the secretions in the airway. Now, if you provide 100% oxygen, which already contributes to absorption atelectasis, and you also apply suction, active suction to the endotracheal tube, this provides a sure-shot formula to produce atelectasis. And several studies have come out now where you give a vital capacity maneuver and follow it up with breathing 40 to 60% oxygen, which keeps the lungs open, because if you give 40 to 60% oxygen, the remaining is nitrogen. And as we said earlier, nitrogen keeps the alveoli open. So by giving a vital capacity maneuver, we recruit as many alveoli as possible, and we maintain oxygenation at safe levels while at the same time not contributing to absorption atelectasis. We come to the third concept, which is the closing capacity. And what is the relationship between functional residual capacity, closing capacity, and residual volume? As you can see, the term closing capacity has been strategically placed between FRC and residual volume. And the reason for this is, as we breathe out from our functional residual capacity level right down to the residual volume level, a time comes when small airways start to close. There is closure of the smaller airways at a particular point above the residual volume, but below the functional residual capacity, at which small airways start closing. So that volume at which small airways close is what is called the closing volume. And closing capacity is just an extension of this term. It is sum of the residual volume plus the closing volume above the residual volume at which small airways begin to close. Now, why do we need to know this relationship between functional respiratory capacity, closing capacity, and residual volume? How does this affect ventilation to lung units? We are already familiar with this particular diagram. We know that the three lines, the red line, the green line, and the blue line, the sloping three lines, are indicative of how the FRC changes from as we age in the sitting position, the supine position, and the supine position with anesthesia. Now, superimposed on these three lines is a yellow dashed line, which is the closing capacity line. And we define closing capacity as the volume that remains in the lungs at the point when small airways begin to close. So what does that mean? What it means is that even before we reach, the residual volume point of our breathing maneuver, several airways are already closing up, and as a result, several alveoli are already not taking part in gas exchange because they have just got shut off from the exchange units of the lung. Now, let us look a little further as to how this changes with age. The red arrow now points to that point where the dashed yellow line, the closing capacity line, intersects the FRC line in the sitting position. And you can see if you were to extrapolate that red arrow down to the x-axis, it is coming to roughly somewhere around 65 years of age, which is approximately the age at which I am now. And what that means is that even though I am now in the sitting position, which is most optimal for breathing, most optimal for the diaphragm to move downwards and create gas exchange, even though I'm not lying supine, even though I'm not anesthetized, despite my not having any pulmonary pathology, already several parts of my lung are shutting down because of my age. And this leads to ventilation-perfusion mismatch and leads to reduction in oxygenation with age. Let's see what happens in the supine position. The green arrow now points to the intersection of the closing capacity line with the green line, which is the FRC line in the supine position. And again, extrapolating that line downwards, you find that this happens at around 45 years of age. So in the supine position, even those of us who are in our middle age, roughly around 45 years of age, already have some parts of our lung that are shutting down in the supine position. And you go further and you anesthetize patients in the supine position, you find that around 30 years of age, you find that the closing capacity is already exceeding the FRC. And so a lot of lung units are actually getting shut down with the induction of anesthesia. And this we need to keep in mind because modern anesthesia workstations provide us the capability of overcoming this problem with the induction of an anesthetic. So when we say areas of the lung are shutting down, what it means is that they are no longer open to take part in gas exchange, they're just collapsed, and a collapsed alveolus leads to a shunt unit. Now, it is surprising to know that atelectasis appears in almost 90% of anesthetized patients. 90% of patients given general anesthesia, 9 out of 10 patients, do have evidence of atelectasis. And the areas that get atelectatic earliest are the ones that are in the basal and posterior regions of the lung, because in the supine position, the diaphragmatic movement is restricted by the pushing of the abdominal contents, and 15 to 20% of atelectasis actually happens in the both basal and posterior lung regions. And this happens the moment we start inducing anesthesia with our intravenous induction agent. Remember, we don't even have to intubate our patients. The moment we induce our patients with an intravenous induction agent, and even before the surgical insult has started, atelectasis has started taking over in several parts of the lung. Now, this becomes even more acute in patients who are, who have, atelectasis, obese individuals during laparoscopic surgeries, especially in the lithotomy or Trendelenburg positions. These are more prone to develop atelectasis, and we need to keep certain tricks that are up our sleeve. And those 3 tricks are listed for us here in this particular slide. They are the sigh breaths, the use of positive end expiratory pressure, and recruitment maneuvers. Now, when you talk about a sigh breath, it is nothing but a breath that is about 1.5 to 2 times the normal tidal volume breaths. So this can be set mechanically, or you can take over to hand ventilation and give a large sigh breath and open up all the atelectatic areas. You can also use a positive end expiratory pressure of 5 to 10 centimeters of water to keep the alveoli from collapsing at the end of expiration. And we can use a recruitment maneuver, which is nothing but periodically inflating the lungs to a peak airway pressure of 40 centimeters of water, holding it there for about 6 to 8 seconds, not longer than 8 seconds, and then allowing the patient to go back to normal tidal volume breathing. These three maneuvers help us to overcome atelectasis. And what you see here is the CT evidence of what happens. The top left panel shows what happens in the awake state. Obviously, I want you to concentrate on the posterior basal regions of the lung. And this is jet black here, indicating that no atelectasis has happened. Induction of anesthesia at zero end expiratory pressure or an airway pressure of zero, find that already whitish areas are appearing in a semilunar fashion in the posterior basal regions. Anesthesia with peak airway pressures of 20 centimeters of water, still you find evidence of these basal atelectasis. And when you raise the airway pressure to 40 centimeters of water, magically all these areas disappear. And this is evidence for us that recruitment maneuvers do work. And use of CPAP also is useful when, or CPAP or P for 5 to 10 centimeters of water is useful when we anesthetize patients, irrespective of the duration of time. Now, let us look at the definition of compliance. I said that no talk on respiratory physiology would be complete without bringing in compliance and airway resistance. The compliance is nothing but the degree of distensibility of the lung or the alveolus, if you take it that way. So it is defined as the change in volume per unit change in pressure, and the equation for it would be compliance equal to delta volume, change in volume, divided by delta pressure, a change in pressure. The units are liter per centimeter water, and the normal value is 0.1 liter per centimeter water. Let's look at airway resistance as one of the pulmonary mechanics that we need to remember to understand both what happens in health and in disease, the lung. The airway resistance is nothing but the impedance offered to the movement of gases down the airway, and the units for airway resistance are centimeter water, that is a measurement of pressure, per liter per second, which is a measurement of flow. So it tells us that it is measured in terms of centimeters of water, and it is one of the factors that controls airway resistance, the rate of flow of gases into the lungs, which is the liters per second. So the pressure drop in linked to the flow rate of gases in liters per second is the units of airway resistance. And what's the normal value? The normal value is about 0.5 to 2.5 centimeters of water per liter per second. Now, what contributes to airway resistance? We can divide the airway into three parts. The nose, mouth, and upper airway contribute to what we call the upper airway. The tracheobronchial tree, starting from the glottis downwards till the 17th or 18th generation of the tracheobronchial tree, is what constitutes the conducting pathway or the conducting airways of the tracheobronchial tree. And the small airways of the respiratory bronchioles, which measure less than 2 millimeters in size, are the ones that actually take part in gas exchange from there onwards down to the alveoli. And these are about 2 millimeters or smaller in size. Now let's look at each of these areas of the airway, so to say, starting from the external nares right down to the respiratory bronchioles, and what percentage of airway resistance do they contribute to the overall 100% airway resistance. Looking at the nose, mouth, and upper airway, we see that 50%, half of this airway resistance is actually contributed to by the nose, the mouth, and the upper airway. And this is not surprising because when you look at the inside of the nose and the upper airway, starting with the nasopharynx, the oropharynx, and the laryngopharynx, it has got an irregular surface, and irregular surfaces lead to turbulent blood flow, and with turbulent blood flow, the resistance to airflow increases. So it's not surprising that from the nares right down to the glottis is the region which contributes to 50% of the airway resistance. The entire tracheobronchial tree contributes to a further 30% of the resistance. So between These two, by the time we reach the small airways, less than 2 millimeters in size, 80% of the airway resistance has already been taken care of. And it is only 20% of the remaining airway resistance that is contributed to by the small airways. Now, I'm explaining this in a bit of detail because intuitively, one would think that as the airways become smaller and smaller, we would imagine that the airway resistance would increase, and there's nothing wrong in that logic. But what we need to remember is that as the tracheobronchial tree continues to divide, there are further and further generations starting from the main trachea right down to the 17th or 18th generation of the tracheobronchial division. You find that the number of small airways increases tremendously because each of these small airways now leads to a grape-like structure of alveoli leading from there, and the smaller airways therefore are very small. But when you look at the overall cross-sectional area, the overall cross-sectional area is far increased. So if you look at this diagram, along the x-axis it shows these purple dots, and if you count from 0 to 10 or the divisions of the tracheobronchial tree up to division 10, you find that there's hardly any increase in airway resistance. But from 11th, 12th, 13th, 14th, and so on, till we reach the 15th or 16th or 17th generation of the tracheobronchial tree, the cross-sectional area increases drastically. And when the cross-sectional area increases drastically, the rate of flow of gases comes down, and therefore the airway resistance also comes down. So this is how we need to try and understand how, though the airway caliber narrows with smaller airways, the overall cross-sectional area increases, and the contribution to the total airway resistance by the small airways is practically only 20%, while larger airways and the upper airways from the nares up right down to the glottis basically contributes to about 50% of the airway resistance. Now, why do we need to know about airway resistance? We need to know this because as long as air flow within the tracheobronchial tree is laminar, the resistance to airflow is there, of course, definitely. But the moment the airflow becomes turbulent, the resistance to airflow increases tremendously. Therefore, wherever the airway resistance is high, that is the part which contributes to the maximal airway resistance because of the turbulence in the airflow. And it is therefore the larger airways that contributes to the maximum airway resistance. And which is also the reason why, when a person has an obstructed, has got, let's say, a congested nose, there's congestion in the nose, we use decongestant drops in order to shrink the mucosa so that the airway caliber increases, and we definitely find it easier to breathe once the upper airway gets decongested. Now, there are other conditions like, papillomas of the larynx, airway obstruction due to laryngeal edema, post-extubation stridor, croup. These are all conditions where the airway resistance increases tremendously in the upper airway. And in these situations, we can make use of a helium-oxygen mixture in order to overcome the increase in airway resistance that these pathological conditions contribute to. We'll come to the next concept of ventilation, perfusion, and its distribution. And this, of course, is a huge topic by itself. And I shall try and summarize that in the next 4 or 5 slides. When you talk about ventilation, perfusion, and its distribution, what we mean is that how is ventilation and matched to the perfusion? Now, the primary function of the lung is gas exchange. I mean, that's basic knowledge. And for any gas exchange to occur, air and blood need to be brought into close proximity. And this is what is done by this beautiful structure that we call the alveolar capillary membrane, which is just a very thin membrane which has air on one side, on the alveolar side, and pulmonary arterial blood or deoxygenated blood on the capillary side of the alveolar capillary membrane. And across this thin membrane, we get exchange of oxygen and carbon dioxide, which is essentially the reason why we breathe. Now, if you look at a functional lung unit, you can imagine that this diagram here could represent a single alveolus, or it could represent the entire lung. And these double-headed arrows, which are shown here, the top double-headed arrow indicates the movement of air in and out of what we call the anatomical dead space, and the lower double-headed arrow indicates the movement of air in and out of what we call the alveolar ventilation or the alveolar spaces. Now, if you were to just take the first uh, number that we remembered in the earlier part of the lecture today, we said that the normal tidal volume is around 500 ml in a patient who is weighing about 70 kilos. And when you have a 500 ml tidal volume and the person breathes about 15 times a minute, the minute ventilation is about 7.5 liters. But remember, 150 ml of this tidal volume is actually taken up by the anatomical dead space, leaving only about 350 ml, 500 minus 150, to take part in alveolar ventilation. So when you multiply 350 by a factor of 15 breaths per minute, you get a value of approximately 5000 ml per minute, which is a number that we shall remember to be equivalent to the alveolar ventilation per minute. Look at the other side where you find pulmonary blood flow, which is nothing but the cardiac output. And we know that cardiac output is around 5 liters per minute again. And therefore, we have a very nice ventilation to perfusion ratio of 5000 ml of alveolar ventilation to 5000 ml of pulmonary blood flow, which gives us a ventilation perfusion ratio in an ideal situation of 1. Now let's look at independently the distribution of blood flow and the distribution of ventilation. Now the blood flow to any organ will depend upon the cardiac output, and the lung is no different. Therefore, the total amount of blood flowing into the lungs, which is equal to the cardiac output, is, as we mentioned earlier, about 5 liters or 5000 ml per minute. However, the distribution of blood flow in the lungs is not equal when you look at the top and the bottom of the lung. And there is a hydrostatic gradient, which is gravity dependent, that governs the blood flow to different parts of the lung as you go from the top of the lung, which is possibly the least perfused part of the lung in an upright position, to the bottom of the lung, which is the most perfused portion of the lung in the upright position. Now, this is the classic diagram, which was described by Sir John B. West, who is a leading authority in respiratory physiology. And I will explain this a bit because if you understand this, that makes life very simple for us to explain ventilation perfusion and its ratio, so to say. You have the lung is divided into 9 slices. The topmost slice is this one, and as we go down the slices, 1, 2, 3, 4, and all the way down to the 9th slice, you have 9 slices of the lung. And on this particular diagram, you have the first column and the third column having some numbers. The first column indicates the percentage volume of the total lung volume that the topmost slice of the lung represents, which is roughly about 7% of the total lung volume. Going all the way down to the 9th slice, you have 13% of the total lung volume. And when you look at the total, in between you'll have different numbers ranging from 7 at the top to about 13 at the bottom. And the total of all these numbers would total to 100% of the total lung volume. When you look at the distribution of blood flow, as I told you earlier, there is a hydrostatic gradient that allows more blood to flow to the bottom of the lung as compared to the top of the lung. And in actual numbers for us to remember, Q dot indicates the flow per unit time. So therefore, the topmost slice of the lung receives about 0.07 ml, sorry, 0.07 liters, I correct myself, per minute, whereas the bottommost slice receives about 1.29 liters per minute of blood flow. And in between, if you add up all the numbers, once again, you'll get a total cardiac output or a total pulmonary blood flow of 5 liters per minute. Now, to put these things in right perspective, we need to look at the flow of blood per unit lung volume, and therefore we will divide 0.07 by 7, which gives us very easy mathematics, a value of 0.0 per minute per percent lung volume. We do a similar exercise with the numbers in the lowermost slice. Take this as 1.3 for easy calculation. 1.3 divided by 13 will give us a value of 0.1. So as you look at 0.01 liters per minute per percent lung volume at the top of the lung and 0.1 liters per minute per percent lung volume at the bottom of the lung, this is what brings us to the conclusion that receives 10 times as much blood flow per unit lung volume as compared to the apex of the lung, and that's what is mentioned here on the slide. Now let us again diagrammatically represent this. On this diagram here, you have the x-axis which shows the top of the lung to the right of the x-axis. So that's the first rib. And as you go from the right to the left, you find the second, third, fourth, fifth, and go all the way down to the 12th rib. And along the y-axis, you have the liters per minute per person lung volume, which is what we calculated earlier. So when you look at this, at the top of the lung, you're getting roughly somewhere here, you'll get a value of 0.01 liter per percent lung volume. And at the top of the lung, 0.1 liter per percent lung volume. That is how we come to the conclusion that from the top to the bottom of the lung, there is a tenfold increase in blood flow per unit lung volume. Let's try and remember this diagram as we move along to the later part of the lecture. Now let's look at distribution of blood flow. The distribution of blood flow the distribution of ventilation. We've already seen the distribution of blood flow. The distribution of ventilation, once again, is slightly different because the right lung represents 55% of the total lung volume, whereas the left lung represents 45% of the lung volume. And that is because the left hemithorax also has to accommodate most of the heart. And therefore, the right lung and the left lung contribute to 55 and 45% not only of the lung volume, but also of the ventilation respectively. Now, because of the cephalad displacement of the diaphragm in the dependent lung regions in the supine position, there is a stretch of the diaphragm in these regions, and these tend to ventilate better than the areas that are not stretched. Now, let's go back to look at ventilation and how that differs from the top slice to the bottom slice. In the second column here, you have a number of 0.24 liters per minute of ventilation. And in the bottommost slice, you've got 0.82 liters per minute in the bottommost slice. That's roughly about 3.5 times in absolute terms of increase in ventilation from the top slice to the bottom slice. But if you were to divide the alveolar ventilation per percent lung volume, I've already done that, you'll find that there is a 1:2 ratio. In other words, the top of the lung receives half as much ventilation as the bottom of the lung per unit lung volume. And that is what is shown here on this blue line here. If you were to extrapolate this line here, you'll get roughly about 0.03 liters per percent liters per minute per person lung volume of ventilation at the top of the lung, and at the bottom of the lung 0.06. So 0.03 on top, 0.06 approximately at the top. That's a ratio of 1:2. Now, what is ventilation perfusion ratio? The ratio of ventilation to perfusion, what has been inscribed here by this curved green line. And if you look at this, there are 9 representative dots on this particular curve. And what this shows here is at the top of the curved line, the topmost dot represents the top of the lung, the topmost slice of the lung, second slice, the third slice, the fourth, fifth, and so on, till we come to the 9th or bottommost slice of the lung. And if you look at the ventilation perfusion ratios, a point at which these 3 lines intersect is roughly equivalent to a ventilation perfusion ratio of 1. And the axis, the y-axis, the second y-axis shown here to the right is actually the ventilation perfusion ratio. At around the hilum of the lung, the ventilation perfusion ratio is 1. As you go away from the hilum of the lung, the ventilation perfusion ratio is actually higher than 1. It's actually 3.3 at the top of the lung. And as you go to the bottom of the lung, it's roughly about 0.63. And this is what we can understand. What is the impact of this on the oxygenation and on the carbon dioxide removal? Let us concentrate for a moment on the middle part of this diagram. Again, we are familiar with this alveolus, a representative functional unit of the lung. The blue box on top tells us what is the composition of gases coming into the tracheobronchial tree. And in humidified and warmed gases, the oxygen partial pressure or the oxygen tension in the inspired air is roughly 150 millimeters of mercury, and the carbon dioxide is negligible. It's 0 millimeter mercury. In the bottom red rectangle, you get the composition of pulmonary arterial blood, which is a deoxygenated blood. It has got a value of 40 millimeter mercury of oxygen and 45 millimeter mercury of carbon dioxide. Now, we have said that the alveolar capillary membrane is a thin membrane that allows exchange of oxygen and carbon dioxide across this thin membrane. So when you look at exchange of oxygen, oxygen comes in as 150 millimeter mercury. gives up some of the oxygen to the pulmonary arterial blood, which is the deoxygenated blood, which is at a 40 millimeter mercury tension, and eventually reaches a value between 150 and 40, which is 100 millimeters of mercury. Similarly, carbon dioxide comes in as 0 millimeter mercury, absorbs some of the carbon dioxide from the pulmonary arterial blood at 45 millimeter mercury, and reaches a value of 40 millimeter mercury. So if you were remember, I would like you to remember these numbers: an oxygen tension of 100 millimeters of mercury and an oxygen carbon dioxide tension of 40 millimeter mercury, which is what is the value that you find in the ideal alveoli, and this is basically what is the composition of blood that also flows out of an ideal alveolus. Now, when you look at the right side of this ventilation perfusion line, the blue line extends up to a point where there is no perfusion and total ventilation. And this is what we call a total dead space. At the other end of this ventilation perfusion line, you get no ventilation at all, but total perfusion, and this is resulting in a total shunt unit. Now, as you move towards the top of the lung, you get, as I said earlier, a value of around 3.3 is a ventilation perfusion ratio, and therefore you get a value of oxygen that is somewhere between 100 and 150, and a carbon dioxide value that is somewhere between 0 and 40. And when you do a similar exercise to move down to the bottom of the lung, you get values that are somewhere between 100 and 40 and 40 and 45 as you go to the bottom of the lung, which is what you see here. At the ideal alveoli, which is around the hilar level, you get alveoli and the blood draining these alveoli having an oxygen tension of 100 millimeter mercury and 40 millimeter mercury of carbon dioxide tension. As we move towards its apex, it becomes more and more like the composition of air that we breathe in. And as we move to the bottom of the lung, it becomes more and more like the composition of the pulmonary arterial blood that is flowing into these particular alveoli. So I think I will stop again at this point because we've already covered about 45 minutes. We'll take a break and I'll continue with the rest of part one when we go to the other side of this break. Thank you.